Hello, everyone. So we're going to start the session about injectables and plus. Here we are with Dr. Roya sharing this session. We are very pleased to do that. Your microphone is working, right? So
Yes.
Let's go into it immediately and let's call Dr. Sathi Meenu, right, from India. She has her practice near New Delhi. And you know how Indian people, they are good in all of this, on aesthetics and new protocols and so on. And welcome to Dr. Nalini. Yes, please, you can start.
Hi, I'm Dr. Meenu Sethi. I'm from India. I have practiced in Gurgaon, and I have 2 centers there in the name of Skin Stories. So as we all create stories for our patients, yeah. So I'll be talking about efficacy of intradermal injections of tranexamic acid, glutathione, hyaluronic acid in treatment of melasma. I did a case series, and that is what I'm presenting today. So we all know melasma is a chronic relapsing skin condition. There is a significant social and psychosocial impact. Conventional therapies often are incomplete, they are temporary or poorly tolerated. So intradermal tranexamic acid, glutathione and hyaluronic acid gives targeted local delivery, reducing the side effects. The systemic side effects are almost minimal, and they are effective for recalcitrant cases. Now, we all know tranexamic acid reduces UV prostaglandins, reduction of tyrosinase, and finally the reduction of melanin synthesis. Hyaluronic acid at the same time has an important role in skin hydrodynamics, hydration. It has anti-inflammatory and antioxidant microenvironment. Glutathione inhibits tyrosinase. It shifts eumelanin to pheomelanin and lightens the pigmentation. So the aims and objectives of my study was to assess the efficacy of intradermal injection of tranexamic acid, glutathione, and hyaluronic acid in treatment of melasma refractory to topical treatments. So my material methods included a study design which was a retrospective case series. The population was melasma patients who are refractive to topical therapies. And my sample size was about 10 patients, which I had done, which I'm still doing, and this was like a small case I wanted to share here. The exclusion criteria was specifically patients who are having hypersensitivity to tranexamic acid, pregnancy, lactation, bleeding disorders, and any concurrent melasma treatment going on for them. They were excluded from the study. Any active diseases on the site, like acne or any other inflammatory conditions, we had taken those patients off treatments, off the cases, and OCPs or any interacting drugs like NSAIDs and phenytoin. The data was collected with history examination and informed consent. M-MASI score was calculated at baseline, and investigations included CBC and the coagulation profile. The intradermal injection of tranexamic acid, glutathione, and hyaluronic acid was given. 3 sessions at 2 weeks interval. M-MASI score was recorded 1 month after the last session. We all know about the modified M-MASI scoring. I don't want to go into the details of this. We all calculate this every time we do scoring. The socio-demographic profile included patients, mostly were in the age group of 40 to 50 years. Then around 40% of patients were between 30 to 40 years, and there was 10 patients who were, there were 1 patient who was among 20 to 30 years. All my patients were females, and they were mostly had a gradual onset. Most patients had a malar melasma, followed by centrofacial and mandibular. Then most patients had mixed melasma, and dermal and epidermal melasma was the same ratio. So before treatment, this was the MASI score, which we calculated, and after treatment, there was a significant improvement, which is approximately 77.5% after the sessions. There was the local side effects were mild burning sensation. So all my patients feel that burning sensation when I'm doing the intradermal injections. All the patients, like most patients, like about 60% had that localized burning. Wheals was present, which lasted for about 24 to 48 hours. So I always tell my patients about it, that it will take that much time. Erythema was present in about 90% of patients. This is my first case, which was done, and this is the result after the 3rd session. This is after the 1 month after the third session. This is the profile view for the patient after 3 sessions. So this is the review of literature. Intralesional tranexamic acid has been already well published and studied. There was a 12-week pilot study which was done wherein 72% of centrofacial melasma was significantly improved after 12 weeks of treatment. Another study said intradermal tranexamic acid was compared with topical tranexamic acid, topical triple combination, and it was found to be more effective with very few side effects. There was another study wherein intradermal tranexamic acid versus glutathione microinjections were done, and there was significant visual analog scales reduction in both groups, and there was a more significant improvement than glutathione with patients who had taken tranexamic acid injections. Mesotherapy included tranexamic acid, ascorbic acid, and glutathione was done. It was a split phase trial where there was significant massive reduction with the combination than vitamin C alone. So intradermal injections, glutathione and hyaluronic acid are safe, well tolerated, efficacious for melasma refractory to topical therapies. It is an effective standalone treatment or combined treatment, particularly for dermal and mixed melasma patients. It is a valuable addition to therapeutic arsenal for challenging dermatological conditions. We all are struggling with melasma patients. My limitation was a small sample size. There was a lack of control group and lack of long-term follow-up because I'm still doing this study. Thank you very much.
Thank you very much.
Next speaker is Dr. Okon Magali, and she's going to talk about the standardized 5-point hyaluronic acid injection for the correction of lower eyelid bags, a prospective study. The stage is yours.
Hello everyone, thank you to be here. And let's start with this lecture. I will share the outcomes of standardized technique to treat lower eyelid bags using hyaluronic acid. And a quick disclosure before we continue, this work was not supported by any direct or indirect funding. And let's start with this word, fatigue. Fatigue is what lower eyelid bags convey, and with it, a lower and tired appearance. For these reasons, most of the patients want to treat them, but non-surgical options today are limited. And there are several options or theories about why lower eyelid bags develop. Most of them agree on the role of aging and ligamentous laxity. Ligamentous loses strength, the support is compromised, and the midface architecture changes. And this is when the lower eyelid bags becomes clinically evident. We know that this topic is a challenge in our daily practice. This is generally due to the formation of edema and uneven results. And this is why a structural and standardized approach is needed. For these reasons, we did a study to evaluate structural injection technique, as I referred, targeting 5 superperiosteal sites with different cross-linked hyaluronic acid according to anatomical needs, seeking to improve 2 things. One of them was the efficacy of lower eyelid bags correction by focusing on restructuring the eyelid tick junction, and another was to reducing malar edema. This study was a prospective observational study. We treated 26 patients. We did a follow-up up to 6 months, and in a subset up to 16 months, and we published it in PRS Global Open 2025 last year. This study design allows us to evaluate safety, durability, and clinical outcomes in standardized way. And I want to focus in this slide because patient selection is part of the plan. Standardized technique requires a standardized cohort. We selected patients with lower eyelid bags without previous treatment, and we exclude skin laxity, malar mounds, and festoons. A homogeneous cohort allows us to obtain consistent results. Let's talk about the procedure. As I told you, we standardized 5-point technique to design and restore structural support of the eyelid tick junction. We selected deep plane with small volumes to minimize the risk of complications. And let's talk about the key to this technique, the 5 points. The first two were between the vertex of the zygomatic arch and the orbital rim over the lateral portion of the suborbicularis oculi fat. The third point was at the zygomatic process of the maxilla. The fourth point was just below the infraorbital fossa. And the fifth point referred to as the pearl rosary along the tear trough and infraorbital rim, following the point-by-point technique. Regarding the dose, the volumes were adapted according to the function of each injection point. We used up to 0.3 in the malar zygomatic area and up to 0.02 in the infraorbital area. The first injection points allow repositioning of the treated area, and the points along the infraorbital rim help integrate the eyelid-tick junction. Regarding the filler selection, we selected hyaluronic acid for its reversibility and safety. We must select different rheological profiles for different anatomical needs to meet face support, because we want to improve the structure, and areas requiring more precise integration into thinner tissues. The aims were to reduce the risk of irregularities and persistent edema. How we evaluated the outcomes? With standardized clinical photography, with vector analysis, and with gaze scale on days 0, 30, 60, 3 months, and 16 months, where he can see the sequential standardized photographs that show progressive clinical improvement in a region traditionally associated with complication. Achieving these outcomes is clinically relevant. There is another patient that shows us the reproducibility may be one of the strengths of standardized approach. Another one, and let's go back with our patient. We evaluated with vector analysis. Vector can see the volume change, and we can see the volume gain, and with the grayscale, we can see the volumetric enhancement and midface contour improvement. All the patients rated their outcomes as much better on day 60. It maintained up to 6 months, and in a subset up to 16 months. But although these results should not be extrapolated to the full cohort. Regarding safety profiles, no serious adverse events were observed. Ecchymosis and contusions were common but resolved spontaneously. And as expected, all the patients experienced an eyelid edema infraorbital, but resolved spontaneously on day 60 without intervention. One of them required hyaluronidase. Small sample size and the absence of an independent evaluator were study limitations. And some messages to take home: standardization may be the key to reducing edema and variability in lower eyelids treatments. Working in a deep plane and with small volumes matters, and we can achieve safe and reproducible outcomes clinically effective in selected patients. Here are the references, and that's all for me today. Thank you for listening.
Thank you so much for your presentation.
So now we're gonna welcome Dr. Wang Guabao. Let me wonder, where are you from? Philippines? No. Oh, China. I'm sorry. I'm so bad. So he's gonna talk about in situ tendon regeneration after resection of the palmaris longus, a case report.
Thank you very much.
Please,
Yeah.
you can.
Hello, everyone. My name is Guobao Wang from Department of Plastic Surgery at the Tongji Hospital of Tongji University in Shanghai, China. Today, I'd like to share a very rare case on something quite remarkable: the spontaneous in situ regeneration of a human palmar longus tendon after complete resection. Just a brief about myself. I'm a plastic surgeon and associate researcher at the Tongji Hospital. I'm a member of ICEPS. My published SCI paper as the first author have a total impact factor of about 39. I also serve on the editorial board of the ASJ Chinese edition and the OPEC. Let me start with the background. The conventional understanding in our field has been that tendons don't really regenerate. The current approach to repairing a tendon defect is tissue engineering. You grow the tendon in vitro. We need a biological scaffold, and so far, this has only been successfully done in animal models. That what got us thinking, could this actually happen naturally in a human patient? Could we observe spontaneous tendon regeneration without scaffold, without in vitro engineering, without any exogenous intervention? That become our driving questions. So we finally came across the case we'd been waiting for. This is a very rare case about an 18-year-old male who sustained a right index finger snake bite 2 years prior, resulting in extensive tendon loss in his finger. We reconstructed the tendon with about 5 mm palmar longus graft harvested from his distal forearm. 1 year later, we returned for a second graft using the residual mixal palmar longus tendon. Intraoperatively, we unexpectedly discovered the tendon-like tissue had regenerated at the distal harvest site where the tendon had been fully excised a year before. We completed the scheduled surgery with the proximal tendon and biopsied the regenerated tissue for lab testing with the patient's family consent. So once we had the tissue, the question was, is this real tendon or is it just a scar? To answer that, we designed a 4-level evaluation. First, gross examination. What does it look like? How does it feel? Second, histology. We use 3 different staining. HE for overall architecture, Mason trichrome for collagen content, and picrocirrus red under polarized light for collagen fiber organization and maturity. Third, immunohistochemistry. We look for collagen 1 and collagen 3 and the tunnel modeling. Tunnel modeling is a well-established tendon-specific marker. And the fourth, biochemical testing. We measured elastic modulus, ultimate tensile strength, and the maximum displacement before failure. If the tissue looks like tendon as the collagen architecture of the tendon express the tendon markers and perform like tendon mechanically, then we've got a convincing case. Let me show you what we found, starting with gross examination. This is the case. The regenerated segment measured 5.2 centimeters in length. Visually, it retained a tendon-like fascicular architecture. It was translucent, firm to the touch, and had a reasonable elasticity. Next, the mechanical properties, like the elastic modulus, came out at 62 megapascal. But the real question is, how does that compare to normal tendon? Let's look at the next. For reference, normal human tendon has an elastic modulus in the range of about 50 to 150. The regenerated tissue came in at 62, right inside that window. Now, let's look under the microscope. HE staining showed elongated, dense, parallel collagen fiber bundles, the classic architecture you expect from the tendon. Mason's trichrome confirmed the tissue is rich in collagen. However, compared to the normal mature tendon, I think it is important that the regenerated tissue was still somewhat immature. These tell us two things. First, in vivo human tendon regeneration is a slow process. Even after a full year, it hasn't reached complete maturity. It need a longer remodeling period. Second, the immaturity might partly be because this regenerated segment wasn't under normal mechanical loading. Remember, this was a palmar longus tendon that had been harvested, so the new tissue wasn't subjected to the same function demands as the original. This is the Picaro series red staining under polarized light confirmed the same story. The regenerated tissue showed a parallel collagen fiber arrangement, very similar to normal tendon tissue. Finally, we looked at the molecular level with immunohistochemistry. Showed that collagen 1 and collagen 3 are the main structure collagens in tendon, and the tenomodulin we mentioned before, which is a well-established tendon linear marker. All three were positive in the regenerated tissue, with the expression pattern similar to normal tendon. This gives us molecular level confirmation that the regenerated tissue is indeed tendon. And one additional finding, the depinuclear staining showed a higher cellularity in the regenerated tissue compared to the normal tendon. That actually makes sense. You'd expect more cells during regeneration and remodeling. So let me put this all together. We have documented the first case of spontaneous in situ regeneration of completely resected human palmar longus tendon. We evaluated this tissue across 4 independent levels. Structurally, it shows the parallel collagen architecture of tendon. Mechanically, it falls within the normal biochemical range. Molecularly, it expresses tendon-specific markers, including tenomodulin. So, what does this mean? To our knowledge, this is the first reported observation of spontaneous, non-engineered, in vivo, in situ regeneration of a full-thickness human tendon defect without scaffolds, without in vitro culture, without any exogenous biological intervention. It happened naturally. This tells us that humans do possess an intrinsic capacity for tendon regeneration, something that has been doubted until now. Of course, many questions remain. What are the cellular and molecular mechanisms behind this? Can we harness this capacity therapeutically? We hope this case reports stimulates further research in these directions. Thank you very much for your attention. I'd be happy to take any questions. Thank you.
Thank you for a very interesting case, and we will have some question and answer after for you for sure.
Okay.
Okay. And the last speaker is Dr. Andrew Yoshihiro Firia, and he's going to talk about the dual modality rejuvenation strategy. The stage is yours.
Dr. Nalini, please come with us here to share the session. Yeah, please.
Hi.
Come here.
So, thank you for being here. Thank you for introducing me. I know I'm the last session, and you guys just can't wait to finish and go shopping. I understand. So I promise to you, I'm not gonna be boring. I'm gonna promise to you, I'm gonna be fast. Okay?
Don't be fast, we have time.
Okay. I'll start slow. No, I'm just kidding. So, dual mode rejuvenation strategy. So, what is it? Okay, so I want to share with you that a lot of people, they want to, what the most interesting treatment, the most trending treatment right now is a lifting treatment. So people want to get lifted, people want to get younger, right? So just a bit of myself. So not all aging is heaviness, okay? So not all aging means jowls. Not all aging means hush puppy jowls, right? So some aging actually is caused by a depletion pattern, volume loss, a dullness, a crimpy quality, and a poor skin quality. And this is what a facelift, even surgical facelift, cannot fix, okay? So if a surgical facelift cannot fix, I don't think any devices, any tightening devices can fix this. So as we can see here, this is just a list I made out of AI, there's so many lifting devices out there. I'm sure all of you have seen in the exhibition halls. There are so many HIFUs, so many RFs, and so many wavelengths, I can't even keep up. It's like a radio wavelengths, right? So there are so many things. But there's all these devices, they only treat the structure, they want to lift, but they don't refine the skin, okay? So they don't fix the skin quality. They don't fix things from the inside, okay? So the device tightens and supports, but skin remodeling, they hydrate and they restore resilience. They fix the skin quality. But anyone, I'm sure you guys must have understand that patients today want fast, painless, and natural results. Let's say patients come to us for a wedding. They want to do a wedding makeover. They give us 2 weeks. But they give their makeup artist 6 months. They book their makeup artist 6 months in advance. They book their wedding dresses a year in advance, But what do they give us? They give us 2 weeks. You can be as smart as you want, but you can't be Harry Potter, right? So, but my go-to device, if I want something that is fast, if I want something that is made with minimal downtime, this is what I use, okay? This is what I use. It's soprano titanium. It's a 3 wavelengths device. It's a long pulse, 755, 810, and 1064. It gives a 3 effect. It gives a bright and tightening and snatched effect, especially for jaw lines. And it has a very low downtime and minimal pain. So, as I said earlier, so good results can become even better. Okay, all devices, they claim, it goes to this depth, it goes to that depth. Sometimes they claim, each medium, long depth, But tightening alone may not fully address dry skin, thin skin, a crepey skin, a tired appearance, a bad skin quality. Tightening will help appearance, but skin quality will help everything else, okay? So I want to add, I always combine a good injectable. Okay, from what I use is Profhilo, but you can use anything you want. But
just don't mention openly the brands
sorry.
because it's a scientific session. It's not allowed. Thank you.
Yeah. So I'm using a good any injectable you can. Okay, this is what I use. Okay, extracellular hydration, it gives muscle support and skin remodeling support. So from the devices, the devices help what people see, right? But the injectables, it's what from the inside, okay? Hydration, softness, texture, and with the right placement, it can help, it can give a subtle lift. And this is why I choose this, you can choose whatever you want, your favorite injectables. but this is what I use and this is why I use it. So why do I combine? Is because together a device with a good injectable, it gives us a better effect now, and it also gives a longer lasting effect later as well. So the ideal patient selection, so a good candidate is somebody with early laxity, with dull skin, dehydration, and people with very heavy jowls and people expecting a huge dramatic lift would not be the first choice. So this is a before and after of what I do. These are the treatments that I do. This is a slightly younger lady, and this is a slightly older lady, and this is also a slightly older lady. So a patient selection algorithm. So if you want something that is fast, you can do just the device. If you want something that is rather heavy, you can do the contouring route using a surgical facelift or a much heavier device, so to speak, like a heavy HIFU or RFs. And for early aging and for thin and dull skin, you can always combine an injectable with your devices as well. So this is how I do it. Oops, sorry. Well, this is supposed to be a video here. Maybe it's a slight technical difficulties. So how I do my devices, so how I do my injectables, okay? So I don't usually do only standard intradermal injections like the papules you do, or I don't also do the BAP points, the 5 points. So I treat the face as a factors, okay? So this is what I do. So the blue ones, I injected deep dermal. I injected deep dermal or just below the dermis. And for the orange thingy on the temples, I sometimes do it and I sometimes do. Sometimes if they have a hollow temples, I sometimes do it. And for the yellow points, those are the ones I do really deep. That's why I say touching the bone deep. And for that part, I do a little bit more. So for each points, I do around 0.1 to 0.2 cc. But if you can add more, sometimes I do up to 4 cc's of the injectables. If you can do 4 cc for injectables, you can put up to 0.2 or 0.3. But if you only have one syringe, 0.1 to 0.2, and for the deep ones, I do a little bit more, especially on the nasolabial folds when you need a little bit more projection. So the take-home point is the aging skin is not a single layer problem, and not a single device can effectively treat everything. Tightening alone may not be enough, and standard injection patterns have limitations. I introduced the booster lift, which is a factor-based skin remodeling injection, and treatment should be anatomy-driven, not just protocol-driven. So you can't treat all aging as the same thing. So thank you very much. I hope I'm not that boring, and I promise to keep it fast. Thank you.
Thank you, Dr. Andrew. So if the attendees have some questions, first, for the first speaker, Dr. Sethi Meenu from India. If no, I have. Do you have? Yeah, so I have a question for you, Dr. Sethi. So first, you show a study, right? You did on 10 patients, combining injectable tranexamic acid, vitamin C, and glutathione. I saw also some vitamin C from ascorbic acid, injectable, which was like just
was a study
topical.
I had done with hyaluronic acid, tranexamic acid, and glutathione. I did not use vitamin C.
I saw something about vitamin C.
I was comparing it with the other studies.
You're comparing with other
yes,
studies.
Yes,
okay.
Yes.
So what you compared? You compared between injectable and topical?
Yeah,
right?
so basically,
how many patients did you inject? How many patients you did topical?
So I have chosen only the patients who were recalcitrant to topical treatments, and the patients who were having dermal melasma, I chose those patients, and I did not do any topical treatments on those patients after that.
Okay, so just injectable.
Just injectables.
Okay, so I want to know the volume, the concentration, and how many sessions. You only one session you done?
No, I had done 3 sessions at a gap of 3 weeks.
3 weeks. But it's very painful to inject tranexamic. You know that?
Yes, it is. But then I had used a concoction which had 4 mg per ml of tranexamic acid, 2% glutathione, and 2% of hyaluronic acid.
It's a pre-prepared solution?
It was a pre-prepared solution.
But it has the CA to be injected?
Yes, it has.
Oh, this is very important.
Yeah.
Yeah, be careful whenever you inject anything, especially when it's mixed. Be sure that it's a really it's made to be injected. It has the CA to be injected because we have so many sterile cosmetic injectable on the market that I have some colleagues even with scar. Like after 2 years, one colleague just came to me during AME Paris conference 3 days ago, telling me that she injected some mesotherapy and she had like really 2 huge scars, and another one have been injected by exosomes. So please, just want to be sure. Unfortunately, we don't have a lot of doctors remaining there to remind them about that, but I have seen a really very bad side effects on my colleagues. So imagine the patient on themselves.
Sure.
Like one, she has a fibrosis after exosome. She can't even not close her eyes. And it's terrible. It's really long term. So whatever you inject, be sure that it has the CA.
Yes.
Okay? I love tranexamic acid.
It is a
even-
wonderful product.
You could also combine with microneedling,
Yes.
tranexamic acid, vitamin C. It would be amazing.
The only problem here in India, what I feel is the post-procedure care, becomes very difficult for patients. So especially with melasma, the kind of photoprotection we need post-procedures is what I feel is a little limitation over there. But otherwise,
With microneedling?
with microneedling,
No, don't worry for that.
Okay.
Go 0.7 millimeters, and trust me, if you combine the injectable plus, because you go deeper with the injectable, plus the microneedling on the superficial layer with the same product, you can have a very good result.
Sure.
And remember, you can also combine it with some laser, with maybe the Q-switch. You can combine it also with other lasers, or the pico laser for pigmentation.
So there should be a gap
Not the
between
same.
this.
No, not the same
yes,
session.
yes.
It
Okay,
gives
sure.
amazing
I
results.
will try that.
Thank you very much.
Thank
It was
you, thank you.
interesting.
Okay. Any question?
Well, let's share something. I think all the treatment skin problems is very good because we have a lot of innovations nowadays. But the thing is that I think the beauty is systemic conditions.
Comes from within.
Exactly.
I agree with that.
So in order to have sustainable, not recurrent, you have to. It's better to approach expanding to approach from within as well.
So we should IV glutathione? What do you think?
Yeah, but we
IV
cannot have it
glutathione?
forever. We need patients to help themselves as well. So what I do is that I'm talking in the first day about melasma as well. So the thing is, from within is at your body, the body and the mind. And that is not enough because you still live in the environment. So no matter what you do, very good, but the environment is not that good. You cannot sleep well. You cannot have good emotion. That is not enough. So we expand it, and then it will make melasma sustainable, like aware of it. The way that I'm approached on the first day is the approach about the Chinese medicine and the Western. Usually the Chinese medicine talk about the emotion or the conditions of the liver, spleen, and kidney. And the Western usually talk about the burnout, the adrenal insufficiency, but actually in our body, everything is holistic. They go to the living matrix.
I absolutely agree with you, Dr. Nalimi. Amazing, but sometimes the pigmentation also has other reason, hormonal, it can be like really different reason, and we help them a lot treating them. So yeah, of course, holistic approach
Our
is
skin, body, mind, and environment, and exactly all the things that modern world, electromagnetic smoke, geopathic stress.
okay. Next time the
approach all.
patient will come to me for melasma, we tell him, okay, do some meditation, heal your body from within, and
Of
it's gonna
course,
disappear.
breathing exercise helps
Exactly.
sympathetic and parasympathetic balance.
I
and
know,
stress
but
reduction.
They need quick results. They need years of psychotherapy and work on themselves to get rid of it.
Okay, Dr. Magali, I have a question. In terms of rheology of the filler that you used,
I
like
use-
in 5 points, is the same rheology or you
I
change?
use for the infraorbital area 22.5, and for the another areas I use 25.5.
You mean the concentration
Yes.
of the HA?
Yes.
And in terms of elasticity, like elasticity or
G
viscosity?
prime, medial
G
G
prime.
prime, yes, and low G prime.
Oh,
Low G prime for the infraorbital area, because I saw that this G prime that is lower than the others don't do the lumps and bumps and Tyndall effects.
And all of 5 points was supraperiosteal, right?
Supraperiosteal. All the
Complete,
points were
all of them.
supraperiosteal.
Okay.
Yes.
But I have a question. I saw
Yes.
1 point under the infraorbital nerve.
Yes.
So it is fine?
Yes, it's
It's
fine.
not painful for
It's
the
fine
patient?
because
Exactly under?
yes, yes, because but this point
Maybe
is
go a little bit.
no. Yes, it could be. It could be. But this point, if you see the slide, is 19 grades. 19 under the infraorbital area.
Oh, you mean
fossa.
below?
Below.
Yeah,
Yes,
not that
below.
the-
Sorry, below.
No, that's okay. Yeah,
Okay, but if you goes 45 grades, maybe you
Because when I
can
do nerve
on.
block, usually for the infraorbital,
Yes.
before injection, I don't inject lidocaine exactly infraorbital. I go a
Yes.
little bit 0.5 millimeters
you
medially.
can do
That just to
both.
have less
Yeah,
pain.
you're blocking the branch. You're
Yeah.
not going directly to the.
You can do both, but is it a safety treatment?
Another thing, so you're using 2 type of molecular weight or SOHO, so you need to use 2
Three.
type of filler.
Three
type of
fillers.
filler. So
Three
it's gonna be
fillers.
very expensive. Maybe surgery is
Yes,
better for
but-
the
but
patient. No.
The patient that don't want to go to surgery,
Yeah,
pay it.
to select the
Okay,
patient
but
that later.
trust me, sometimes it's better to resolve because it's like it's surgical. Actually, it's not
Yes, yes, of
medical.
course. But I
honestly.
have a good results, and the patients they are confident to me, and
how
They
many-
trust you to.
they trust me.
How
so
much ml you use in total?
3
3
3
ml.
3
for
ml?
both
3
sides.
ml.
It's not
3
that
ml.
much.
No, 3 ml for both
3 ml.
sides.
No,
One for
Yeah,
this side,
no.
one
it's a lot. You remember
one
the
from
lymphatic
this side.
system.
I put the dose, another for the another size,
Not all of them
And the low-
infraorbital.
I
She's
know.
doing a
But
cheek
all
area
around,
as
it's
well.
fine, but still, I start always with 1 ml both area. You remember the lymphatic system. You remember the long term.
yes, but the lymphatic
Side
system
effects.
is
I know, but still, remember with fillers in this area,
yes, of
there
course,
is always
but
long term swelling and everything. Don't think about 1 year she will be happy. It's really stay a long time. So my patients 7 years ago I inject them, it's still there.
I still have
Just-
my patients in the office, and they are really really good
Perfect. Thank you very much.
for you.
So some question for Dr. Wang Guobo, who talk about this regeneration.
国宝王
Wobao. So next course, next class, Chinese for me. Regeneration, this very interesting case of autologous, spontaneous regeneration, tender regeneration.
No, I don't.
I have a question.
Okay.
I mean, not a question, I want to think. So here we are in an aesthetic field, okay? So how can you extrapolate it to aesthetic? Do you think we can regenerate the skin naturally and that's the same way and somehow? Or it's just one random case? If you want to extend it to aesthetic, this finding that you have actually in plastic surgery, in reconstructive surgery, whatever, do you think it can be, we can repeat it also about, I don't know, the dermis, the hypodermis?
Actually, for maybe it can apply to dermis, hypodermis, but for tendon, it's very hard to repeat. Yeah, before several years earlier, I do a lot hand surgeries, but now I do more cosmetic surgery, and this patient is very rare because you need to harvest the tendon first, and 1 year later he come back. You open the palmus longus again, and we discovered unexpected discovered the regenerated tissue.
Listen, I believe
Yeah.
really in miracles. Our body
Yeah.
is perfect
Yeah.
and can regenerate by itself. That's why we need to go more into regenerative medicine, platelet-rich plasma, stem cells, like fat-derived, and all of this type of technique. Because really, when you bleed, when you have a scar, you perfectly regenerate. Like because in aesthetic field, we want to overdo, we want to sell some device, we want to sell some technique, some product, but actually, we can really heal by ourselves. Like we won't just stop to aging using, but our body is absolutely perfect. They can maybe sell you some regenerative topical cream and so on, but normally we can repair spontaneously everything, and you know that. Our body is perfect.
Yeah, yeah, yeah. I think this case may promote other doctors do more things to do the further things. Thank you.
Thank you very much. Other question? Okay, okay, perfect, thank you. So someone asked some question for Dr. Yoshihiro Wiria Andrew? Some question for Dr. Andrew, how he combined his device and his injectable. You do it the same session? Dr. Andrew.
So yes, I do it at the same session, especially at my first session. So I do get a lot of the initial results. So patients are happy when they get the initial results. Yes, and I think it's very important for us to actually combine this, because not all aging, as I said, is heaviness, and no one single device can actually help skin quality. So actually, injectables actually helps a lot with that.
And also, I saw some of your point. You go deeply on the needle. Okay, right. You go on the bone deeply, so you don't have risk to catch up the angular artery.
Yes.
But keep in mind still that it's not cross-linked HA, but still it can have the same issue as blood obstructions, like as any necrosis that you can have with needles. So maybe you can try the technique of cannula. It works also as well.
Right.
I talked this morning, I invented 8-point technique on the retaining ligament to strengthen the retainment ligament with non-cross-linked HA, and you can go with only one entry point. We do a 22G cannula, and you can reach the mandibular ligament, the zygomatic, malar, and also the auricular fascia. So you can try also with the cannula, is even safer for the patient.
Completely agree with